Welcome to the Deep Dive. Today we're plunging into a truly critical and frankly rapidly evolving area for all of us in anesthesiology. We're talking about the evolution of pain management in lung cancer surgery. And this isn't just about, reducing immediate discomfort. It's profoundly linked to optimizing patient recovery and maybe surprisingly even long-term oncologic outcomes.
That's exactly right. We're going to be dissecting a very insightful recent review paper today. It's titled Evolution of Pain Management in Lung Cancer Surgery, From Opioid-Based to Personalized Analgesia by Wanzhong Wang. So our deep dive today really traces this incredible paradigm shift. We'll move from those traditional opioid-centric approaches that, well, we all kind of grew up with professionally, then through the more sophisticated multimodal strategies we tend to employ now, and then we'll peek into the honestly exciting and cutting-edge frontier of personalized oncoanesthesia. Our mission for you, our listener, is to really distill the most important, actionable insights from this comprehensive review. Think of it as a shortcut to being exceptionally well-informed in this vital, fast-moving field.
Okay, let's start back a bit. For so long, opioids were just the absolute cornerstone of pain management and thoracic surgery, weren't they? It almost felt like there wasn't another viable way. Can you kind of take us back to that opioid era and explain why they became so deeply entrenched in our practice?
Oh, absolutely. If you look back, say, to the 1990s and even into the early 2000s, opioids were, well, undeniably the primary choice. And, there were compelling reasons for that at the time. First off, their potent efficacy against severe pain was really unmatched. Lung cancer resection, whether it's a big open thoracotomy or even minimally invasive VITS, inherently causes profound postoperative pain. You've got extensive soft tissue trauma, sometimes rib spreading in open cases, neuropathic components. It's significant pain. Opioids delivered powerful, immediate relief.
Okay, so powerful relief, that makes sense.
Right. And second, they were relatively cost-effective and remarkably easy to administer across various settings, 5E, epidural, oral. Plus, intraoperatively, they were crucial for maintaining hemodynamic stability. They helped attenuate those sympathetic responses, the tachycardia and hypertension during these major procedures. So given the sheer challenge of thoracic pain, they just seemed, well, indispensable for both patient comfort and surgical success back then.
Right, but this heavy reliance on opioids, while effective for that immediate pain, certainly came with a significant cost, didn't it? What were the key concerns that started to really push us as a field towards fundamentally different strategies? Because the shift has been pretty dramatic.
Absolutely. The shift was a direct response to a growing and frankly undeniable awareness of a wide range of adverse effects. And these effects, as we now know very well, can seriously compromise a patient's recovery and maybe even their long-term health. We're all familiar with the, let's say, pervasive issues like postoperative nausea and vomiting, PONV, and paralytic ileus. These aren't just minor inconveniences, they critically delay recovery. They impact everything from getting patients eating again to getting them moving, which extends hospital stays and increases costs. It's a big deal.
Delays everything.
Exactly. Then moving to the more serious side, there's respiratory depression. This is particularly perilous in our lung cancer patients. They often have compromised pulmonary reserve before they even get to surgery. So opioid-induced respiratory depression significantly bumps up the risk of hypoxemia, atelectasis, pneumonia, even respiratory failure. Think about open thoracotomy patients. The pain itself causes splinting, breathing shallowly. You combine that with opioid respiratory depression, and it's, well, a perfect storm for complications.
Yeah, a dangerous combination.
Yep. Definitely. We also started understanding opioid-induced hyperalgesia better, that really paradoxical increase in pain sensitivity, where higher doses of opioids actually make patients more sensitive to pain over time, often through central sensitization mechanisms. It creates this vicious cycle: more pain, more opioids, even more sensitivity. And of course, the issue that really captured broader public and regulatory attention, the escalating risk of opioid dependence and misuse. Even from, short-term perioperative exposure, we saw too many patients continuing to use opioids long after discharge, far beyond the acute surgical pain period. That became a major driver for change.
So with all those concerns really mounting, the need for change became pretty undeniable. How did the field begin to pivot away from this heavy opioid reliance? Let's unpack the rise of opioid-free anesthesia, OFA, and opioid-sparing anesthesia, OSA. What's the core distinction there, and how did they gain traction?
Well, acknowledging those significant downsides directly spurred the development of OFA and OSA. OFA, opioid-free, represents the most, let's say, aggressive approach. It completely eliminates intraoperative opioids. Instead, it relies on a carefully chosen cocktail of alternative agents. Things like dexmedetomidine for sedation and analgesia, intravenous lidocaine for its systemic anti-inflammatory effects, and maybe reducing central sensitization. And also, magnesium sulfate and ketamine both are crucial NMDA receptor blockers. That blockade helps prevent the wind-up phenomenon we see with chronic pain development and also reduces opioid
Okay,
tolerance.
so a complete switch in agents.
Right. Now, while OFA is conceptually very appealing, avoid opioids altogether, clinical investigations have actually shown somewhat inconsistent outcomes. Some studies certainly demonstrate benefits reduce POMV, less opioid needed in recovery, faster return of bowel function, things like that. However, other studies report comparable outcomes to traditional opioid-based approaches. And sometimes using higher doses of these alternative agents can introduce their own new risks, like profound sedation or hemodynamic instability, so it requires very careful patient selection.
That's a really important nuance, those inconsistent outcomes. Why do you think we see that variability in the OFA studies?
Yeah.
Is it about patient populations, maybe the type of surgery, or how outcomes are measured?
You've hit on it perfectly. It's definitely multifactorial. Part of it is certainly patient heterogeneity. Not all patients respond identically to these regimens. Think about their baseline pain, their comorbidities, their psychological state. Surgical complexity is another big factor. OFE might be perfectly adequate for, say, less invasive procedures, but for really extensive resections causing severe pain, achieving adequate analgesia without any opioids can be, well, quite challenging. And yes, you're right, outcome measures vary widely across studies, which makes direct comparisons really difficult sometimes. This inconsistency is precisely why opioid-sparing anesthesia, OSA, arguably gained more widespread adoption in practice. OSA offers much greater flexibility, allows for limited and, importantly, judicious opioid use during surgery, but really only when absolutely necessary, while still prioritizing all the non-opioid strategies. I think the key takeaway from recent meta-analyses is that a comprehensive perioperative pain management approach within a broad multimodal framework is ultimately far more impactful than just rigidly sticking to intraoperative opioid avoidance alone. It really emphasizes looking at the entire patient journey, not just focusing narrowly on the OR time.
Exactly, the entire journey. That makes complete sense. So let's elaborate on that multimodal analgesia, or MMA, framework. What does it truly entail in the context of lung cancer surgery, considering both the drugs and the non-drug approaches?
Right, MMA is all about targeting multiple pain pathways simultaneously. You're leveraging synergy between different drug classes and techniques to get better pain control with fewer side effects from any single agent. Pharmacologically, the foundation is robust, scheduled non-opioid analgesia. Think NSAIDs like ibuprofen or ketorolac and acetaminophen. These are cornerstones. They should be given routinely on the clock, not just PRN, to really modulate those inflammatory responses and reduce prostaglandin synthesis. This significantly minimizes the need for opioids later. Then we have gabapentinoids like gabapentin or pregabalin. They're used for the neuropathic pain component, which is very common after thoracic surgery due to nerve handling or damage, though we do use them with caution, especially in elderly patients or those with compromised respiratory function because of the sedation risks. And those adjunctive agents we mentioned earlier, ketamine, lidocaine, magnesium, they're powerful tools. Really useful in selected patients, particularly for preventing that opioid-induced hyperalgesia and just enhancing the overall analgesic effect. Opiates themselves, they become essentially a last resort, strictly reserved for severe breakthrough pain that isn't responding to anything else and always at the lowest effective dose for the shortest possible time.
Okay, so a layered pharmacological approach. What about the non-pharmacological side? Regional anesthesia must play a big part.
Oh, absolutely central. Regional anesthesia is huge here. Historically, thoracic epidural analgesia, TEA, was the undisputed gold standard, especially for open thoracotomy. It provided excellent segmental analgesia. However, its use has significantly declined, particularly with the rise of minimally invasive V8s.
Why the decline in TEA specifically?
Well, several reasons. Complications, while not extremely common, can be serious things like hypotension from sympathetic blockade, urinary retention requiring catheterization, the small but real risk of epidural hematoma or abscess. These risks seemed less justifiable when less invasive, but equally effective alternatives started emerging, especially for VATS where the incision is smaller and pain patterns might be different. So today, paravertebral block, or PVB, is often the preferred regional technique for VAD. It offers comparable analgesia to TA for many patients, but with a demonstrably superior safety profile. It avoids many of those systemic side effects.
PVB is definitely common now. Are there others gaining ground?
Yes, definitely. We're seeing newer fascial plane blocks like erector spina plane block, ESPB, and serratus anterior plane block, SAPB. gaining a lot of prominence. These are often technically easier to perform, usually under ultrasound guidance. They can be done as a single shot or with a catheter for continuous infusion. They provide good pain control, especially for the somatic pain from the chest wall incisions, maybe particularly for anterior or lateral incisions with SAPB. And you see this reflected in guidelines. The 2022 Prospect Guidelines and the 2023 ASA Practice Advisory for Acute Pain Management in Thoracic Surgery clearly recommend PVB or ESPB as first-line options for thoracoscopic surgery, with SAPB as a viable secondary choice. It really represents a shift towards less invasive, safer, yet still highly effective regional approaches tailored to the surgery.
This whole evolution, especially with the multimodal approach and these advanced regional techniques,
Yeah.
it seems to align perfectly with enhanced recovery after surgery or ERAS protocols. How does MMA fit into that broader picture of just optimizing recovery for these complex patients?
Precisely. MMA isn't just part of ERS, it's really a fundamental, you could say indispensable strategy within it. ERS pathways are all designed to get patients recovered and back on their feet faster, reducing physiological stress. Effective pain management with minimal opioid exposure is absolutely key to achieving that. Recent ERS guidelines for thoracic surgery have fully incorporated these OFA or OSA principles, emphasizing opioid use really only in a minimal rescue role, and it goes beyond just pain control and letting patients mobilize earlier. MMA within ERS has also been linked to mitigating the systemic inflammatory response to surgery, which, interestingly, might even have implications for cancer progression itself by reducing that surgical stress response. And critically, a faster, smoother recovery facilitated by the ERS pathway allows for earlier initiation of necessary adjuvant therapies, things like chemotherapy or radiation, which could potentially improve the long-term prognosis for our cancer patients. It's a truly holistic, interconnected approach. It enhances pretty much every aspect of recovery quality across the entire patient journey, from pre-op to post-discharge.
Okay, so bringing it all together for our specialist listeners who are dealing with these cases day in, day out, what are the practical, actionable recommendations that emerge from this review for perioperative pain management and lung cancer surgery right now? What should we really be focusing on in our daily practice?
Okay, the practical framework is actually quite clear and actionable based on this evolution. It really emphasizes preemptive non-opioid analgesia, starting typically 1 to 2 hours before induction with scheduled acetaminophen and an NSA dye, if appropriate for the patient. During the surgery, the focus shifts heavily to regional techniques. For VAT, as we said, ultrasound-guided PVB is often the go-to, or perhaps ESPB or SAPB, depending on technical factors or incision location. We should also integrate the selective use of those non-opioid anesthetic adjuvants, maybe dexmedetomidine for sedation and analgesia, perhaps IV lidocaine, ketamine, or magnesium infusion for their systemic effects, depending on the patient and the surgical context. Postoperatively, it's all about rigorously scheduled non-opioid analgesics continuing the acetaminophen and NSAIDs. If a regional catheter is placed, continuing that infusion is key. And then limiting opioid use strictly to minimal rescue doses, titrated very carefully to validated pain assessments, not just given routinely. The overarching goal isn't just good pain control, although that's paramount. It's achieving it with minimized opioid side effects, allowing for early ambulation, early oral intake, reduced ileus, and overall a faster, smoother recovery trajectory.
Okay, now this is where it gets really interesting and frankly potentially groundbreaking for our field. Beyond simply managing the pain symptoms, this review delves into a fascinating and, I'd argue, vital area, how our specific analgesic choices might actually influence cancer recurrence and metastasis down the line. What's the emerging and honestly sometimes quite surprising evidence here?
This truly raises a fundamentally important question, doesn't it? We used to think purely about alleviating pain. Now, we're increasingly recognizing the perioperative period as this critical window that can influence long-term oncological outcomes. And there's growing evidence, mostly from preclinical lab studies, but also some retrospective human studies, suggesting that different analgesic agents can indeed influence tumor biology in different ways. Take opioids, for instance. They are implicated, potentially, in cancer progression through several concerning mechanisms. One is immunosuppression. They can reduce the activity of crucial immune cells like natural killer NK cells, which are our body's first line of defense against detecting and destroying wandering cancer cells. Another is enhancing angiogenesis. They might promote the formation of new blood vessels that tumors need to grow and spread, partly by upregulating factors like VEGF, vascular endothelial growth factor. And some studies even suggest they could increase metastatic potential by modulating pathways involved in epithelial mesenchymal transition, or EMT, basically helping cancer cells become more mobile and invasive.
Wow, okay, so potential downsides, beyond the usual side effects. What about the alternatives?
Right. In stark contrast, NSAIDs have actually demonstrated potential anti-tumor effects in some models. They work by reducing prostaglandin E2 levels. PGE2 is often elevated in tumors and promotes their growth and suppresses anti-tumor immunity. Some NSAIDs might even directly induce apoptosis or programmed cell death in certain cancer cells. Local anesthetics, like lidocaine used systemically or regionally, also show promise. They have known anti-inflammatory properties, and emerging evidence suggests they might directly inhibit cancer cell migration and invasiveness, possibly through effects on voltage-gated sodium channels, which are, interestingly, sometimes upregulated in cancer cells. Even agents like ketamine and dexmedetomidine have been explored for their potential immunomodulatory properties, perhaps preserving immune function better than opioids during surgery, though their direct long-term impact on cancer progression itself is still quite debated and certainly needs more robust prospective research.
Wait a minute, you mentioned earlier some counterintuitive findings from a study. Are we saying that in some specific cases, the very opioids we've been trying so hard to minimize could potentially be beneficial for long-term oncologic survival? That seems to fundamentally challenge so much of our current thinking. Can you elaborate on the implications of a finding like that for practice and how this leads us towards this idea of precision oncoanesthesia?
That's precisely the groundbreaking and, yes, counterintuitive implication that's emerging. And it leads directly to this concept of precision oncoanesthesia. It represents a potential paradigm shift where we integrate tumor-specific molecular and genetic insights directly into our perioperative pain management decisions. The core idea is that different tumor types, because of their unique underlying molecular characteristics and mutations, may respond very differently and sometimes, as you said, paradoxically to opioids, NSAIDs, local anesthetics, and other agents.
Can you give that specific example again?
Yes, the review highlights a truly fascinating retrospective study involving non-small cell lung cancer, NSCLC, patients. It found that higher intraoperative opioid doses were indeed associated with poorer overall survival in patients whose tumors had CDKN2A mutations. Okay, that aligns with the general concerns about opioids potentially promoting cancer. However, and this is the kicker, for patients in that same study whose tumors exhibited mutations in the WNT or Hippo signaling pathways, completely different genetic profiles, opioid administration was actually linked to improved recurrence-specific survival. It's incredibly counterintuitive, but it powerfully highlights that the oncologic impact of an analgesic isn't necessarily uniform. It seems to profoundly depend on the underlying tumor genotype. It really suggests a future where, for certain patients, we might consciously choose to use a specific opioid, or perhaps actively avoid another, based directly on their tumor-specific genetic profile, to optimize not just pain, but maybe their cancer outcome too.
That's truly mind-bending. The idea that we might someday tailor our analgesic choices based on a patient's specific tumor genetics is revolutionary, almost science fiction territory until recently. But obviously, putting such a tailored precision approach into practice comes with significant challenges. What are the major hurdles we need to overcome to implement precision oncoanesthesia in everyday clinical practice?
Oh, there are indeed significant hurdles, and they really span across awareness, feasibility, and the strength of the evidence itself. First, there's just a fundamental lack, currently, of widespread awareness and integration of tumor biology into routine anesthetic decision-making. As anesthesiologists, we're typically trained and accustomed to using standardized protocols based on surgery type and patient factors, not tumor genetics. The whole concept of precision medicine guiding perioperative care is still very much in its infancy for our specialty. We really need to bridge this knowledge gap.
So education is key.
Education is huge. Second, there's the practical feasibility of getting this information in time. Real-time genomic profiling, specifically for anesthetic planning, is a major logistical challenge right now. Current molecular testing done by pathology isn't usually designed for the rapid preoperative or intraoperative turnaround we might need. We need significant advancements in fast, cost-effective screening technologies that can provide the relevant molecular data preoperatively quickly enough to actually inform our anesthetic choices on the day. Imagine having a patient's critical tumor genetic profile right there at your fingertips before you even start induction. We're not there yet.
Right, the logistics are tough. What about the evidence itself?
That's the third and crucially important hurdle. Much of the supporting evidence we have right now, like that fascinating study we discussed, comes from retrospective observational studies. While these are incredibly valuable for generating hypotheses and pointing us in new directions, they are inherently limited by potential confounding factors and biases. They can show associations, but they can't definitively prove causality. We desperately need large-scale, well-designed, prospective randomized controlled trials, RCTs, to truly establish whether choosing analgesics based on tumor biology actually improves outcomes and to validate these initial findings. Future research absolutely must focus on identifying reliable biomarkers that can accurately predict individual tumor responses to different analgesics.
Makes sense. RCTs are the gold standard.
Exactly. And ultimately, overcoming all these challenges requires profound interdisciplinary collaboration. It can't just be us. Anesthesiologists, oncologists, molecular biologists, geneticists, we all need to work closely hand in hand to develop robust, evidence-based protocols. And critically, as we said, we need to significantly expand education in basic tumor biology and its relevance for anesthesiologists, making this knowledge as integral to our future practice as, say, pharmacology or respiratory physiology is today.
What an incredible journey through this deep dive. We've really seen this monumental shift in pain management for lung cancer surgery. Moving from what was once a standard, almost reflexive opioid-heavy approach
Yeah.
to the sophisticated multimodal strategies we use now, and now looking towards a future where our analgesic choices might be informed not just by pain scores, but by individual tumor biology itself.
If you connect all these dots, it's abundantly clear that perioperative analgesia is evolving far beyond just simple opioid avoidance, although that remains important. It's really moving towards truly personalized approaches, meticulously guided by molecular and tumor-specific information. And the goalposts are shifting too. This isn't just about providing better pain relief anymore. It's about optimizing functional recovery and, most profoundly, potentially influencing the long-term oncological outcomes for our patients. It adds a whole new dimension to our role.
So wrapping this up, what does this all mean for you, our listener, the practicing specialist? This really raises an important, maybe even provocative question for us. How will we, as anesthesiologists, actually begin to integrate these complex emerging genomic insights into our daily practice? How do we make that leap from providing highly effective pain control, which we already strive for, to actively, consciously contributing to the long-term prognosis of our cancer patients through our anesthetic choices? It's a powerful, complex, and honestly exciting challenge for the future of our field. It's something to really think about.